Hello, my name is Brian Butler. Frauke Kreuter and I are the co-directors of the University of Maryland's Social Data Science Center, and we welcome you to the launch of the center. Effectively and efficiently and ethically creating high-quality information products about information activity is absolutely critical for health, education, climate, entertainment, policymaking, government, and just to name a few areas. Addressing the unique challenges of working with social data at larger scale, broader scope, and for novel purposes requires a multidisciplinary community of researchers and professionals. The University of Maryland Social Data Science Center, also known as SODA, leverages UMD's substantial strength in survey methods, measurement, information management, visualization, and analytics to address these challenges and realize the potential of social data to change the world for the better. Over the next 3 days, we'll be discussing the role of social data science in 3 areas: health, business and economics, and privacy. Today, we're going to consider issues and opportunities at the intersection of social data science and health. We're excited to have as our moderator, Dr. Kim Nickerson, the Assistant Dean for Diversity, Equity, and Inclusion at the College of Behavioral and Social Sciences. Dr. Nickerson is a senior leader in the college in BSOS, who also has extensive experience at the intersection of social science and public health. So I'll now turn things over to Dr. Nickerson, who will introduce our speakers and lead today's discussion. Thank you.
Thank you, Brian, for that introduction. And on behalf of the College of Behavioral and Social Sciences, we want to welcome all of the attendees to this very exciting launch of the Social Data Science Center here at the University of Maryland, College Park, College of Behavioral and Social Sciences. I also want to thank the leadership that we have for this really exciting center. Frauke Kreuter, the director of the Joint Program in Survey Methodology, and Brian Butler, who's giving a very capable assist in this Social Data Science Center. You know, one of our mottos in the College of Behavioral and Social Sciences is we want to be the solution to the world's greatest challenges. And health is one of those challenges that requires all hands on deck. And as much technology and knowledge and cutting edge as we can muster. Over the last several years, we've recognized that in attacking these large challenges, it takes more than just universities. It also takes partnerships. So what's particularly exciting about this presentation today and the Social Data Science Center is it represents the leveraging of these partnerships. University of Maryland, our Joint Program in Survey Methodology, our college, and our partners across campus, but also industry as well, as you will see today as we have Facebook joining us in supporting these efforts. As we recognize in efforts like the sequencing of the human genome, these types of partnerships that also include industry and others outside of university settings can be really important as we tackle some of the largest science questions that we have before us. I'm here to moderate this session. And so here's the way we'd like to proceed, and we hope that you will stick with us for the entire time. We have 4 great speakers who will talk about the intersection of social data science and health. Each speaker will present in sequence in 10-minute blocks. At the end of each speaker, I will introduce the following speaker in greater detail. But we won't do a question and answer session at the end of each speaker for the sake of time. Instead, you will see a question and answer logo or icon at the bottom of your screen. As speakers are talking and you have a question, please feel free to put your question in the question and answer box. And when all 4 speakers have finished, I will come back and I'll lead us through a conversation on all of the topics that we've covered. So now I'd like to just give you a brief overview of the 4 speakers we have, but before each begins, I will give a more in-depth introduction for them. First, we're going to hear from Kathleen Stewart, who is a professor and director of our Center of Geospatial Information Science here at the University of Maryland, College Park, and our Department of Geographical Sciences. Next, we'll have In Kyung Chai, who is an associate professor and doctoral program director here at the University of Maryland College Park in our College of Information Studies. Following her, we will have two presentations from our colleagues and partners from Facebook. Catherine, or as she'd prefer to be called, Katie Morris, who's a research scientist in the Demography and Survey Science Unit at Facebook, and our colleague, Sarah LaRocca, who's also a research scientist at Facebook in the Demography and Survey Science Unit. But let's first begin with a 10-minute presentation from Dr. Stewart. Here's more about Dr. Stewart. Dr. Stewart works in the area of geographic information science with a particular focus on geospatial dynamics. She's interested in mobility and spatial access, often in big geospatial data contexts, and using approaches that lie in the expanding field of spatial data science. She investigates movement and mobility for a number of different application domains, for example, health and transportation, where movement patterns or behaviors and spatial access are key topics. She's also interested in modeling geospatial semantics, including geospatial ontologies and their role for location-based applications, and spatiotemporal information retrieval, like computational methods for automatically acquiring meaningful space-time information from text sources. Dr. Stewart teaches in areas of spatiotemporal data modeling, geographic database design, geovisualization, and cartography, and fundamentals of geographic information. So without further ado, Dr. Stewart's presentation today will be on social data science and health, a geospatial perspective. Dr. Stewart?
Thank you very much for that very kind introduction, Dr. Nickerson. Let me share my screen here. There we go. Everyone see that okay? All right, so I'm looking forward to talking to you this afternoon about a geospatial perspective on social data science and health, the topic of our panel this afternoon. I'm going to be touching, we just have a short opportunity to talk today, so I'm going to be touching on 3 different studies that I've been involved in that highlight a geospatial perspective for modeling and analyzing health-related problems. 2 of these studies are going to relate to infectious disease modeling. One is COVID-19 and one is malaria. And then the 3rd study I'm going to talk about just very briefly relates to the opioid crisis, which has had a terrible impact really on many individuals across the United States. And in all of these studies, we're interested with this geospatial perspective in revealing spatial patterns at different scales and determining a possible set of spatial drivers for each health concern. So really focusing on the geospatial aspects of these studies. So let's jump in and talk, or I'll just say a few words about the first topic, and that is a topic that is involving using big, passively collected, location-based data to model mobility pattern changes during the COVID-19 outbreak. This is a project with support from the National Science Foundation. My co-PI on the project is Professor Deb Niemeyer in the Maryland Transportation Institute, and the big passively collective location-based data that we're using from the project is shared with us through our collaboration with the Maryland Transportation Institute. And working on this project with me is graduate researcher Guimin Zhu. So in this work, we're looking at how to quantitatively measure changes in collective movement behaviors in response to the fast evolving COVID-19 outbreak. And when we were developing the ideas for this topic, we were interested in looking, this was early spring, and we were interested in, we decided at the time to look at Florida, not knowing that Florida would become the hotspot that it is today for COVID, in fact. So here in this talk, we're just sort of focusing on analysis for 2 Florida counties, Miami-Dade and Broward County, both adjacent counties. and using location-based data set to give us trips, inflow trips, so trips coming in by census tract. And here, the map that you see is showing trips for May and June, so relatively recently, for these two counties. So we're 14 million trips that we're mapping here and modeling, and shown in conjunction with COVID-19 positive cases. So just for these two counties, and of course, as I'm sure everybody knows from news reports, et cetera, of just the seriousness of COVID in these Florida counties. The case data is from Florida Department of Health data for this same period. And so looking at mobility and COVID cases, we can see the trends for these two counties. The blue graph lines are mobility, and the red graph lines show COVID positive cases. The kind of spiky aspect is showing the drop at weekends for travel, but we can see that during, so this is from early March, 2nd of March, all the way through the end of June. And we can see that really a similar pattern of mobility for these two counties, with really regular patterns of mobility in this kind of June period. I realize probably very difficult for you to read the axis here, but in this June period. And then we see this rising number of cases in each county along with mobility. And maybe we start to see at the end of June a drop off in mobility as the impact of these cases really starts to take effect in these counties. And because we're interested in social data science in today's talk, we want to look also at the relationship of different population groups, different racial and ethnic groups in this area. So we have Hispanic populations being mapped by census tract, again, in comparison to the mobility. Darker colors on the mobility map refer to higher levels of mobility, and also for Black and white populations. And again, just to remind you about what the pattern of COVID positive cases are. So as we well know now, Black and Hispanic population groups have been impacted very highly with COVID, and we certainly see the population here and the differences between Broward and Miami-Dade just in their sociodemographic patterns. So quantitatively, we've been building a random forest model to identify different variables relating to mobility that are impactful for the number of COVID cases that might help us ultimately down the road be able to predict COVID cases possibly. We're looking at sociodemographic variables, age, gender, race, household size, many different variables, as well as mobility factors, including things like distance from beach. We've got Miami Beach, Fort Lauderdale Beach in these two counties, commuting data, working from home data, so quite a range of variables. And in addition, you're going to be hearing in one of the panel talks about the Facebook COVID-19 symptoms survey. And we've taken a number of questions from the symptoms survey and added these into our random forest model, that questions that may particularly impact mobility, like in the past 5 days, have you traveled outside of your state? To what extent are you intentionally avoiding contact with others? And we can look at how these might look spatially. Sorry, just checking the chat there. Spatially, and so we can see with these maps, these are bivariate maps where you can see that the blues represent the responses, number of responses to questions about to what extent are you intentionally avoiding contact by census tract, and that the pinks are, the pink colors are mobility, number of trips. And so the darker purpley blue colors on this map here refers to high trips and a high degree of concern, or sorry, high degree of intentionally avoiding contact. And we kind of see a difference between these two counties, Broward and Miami-Dade, with the more bluey colors about higher intentionally avoiding contact, and then with Miami-Dade, which is kind of more pinky in tone. And then a question on direct contact with how many, so the numbers that you've had direct contact with. Again, we can discern, I think, a spatial difference between these two counties, with Broward being having lower numbers of, higher numbers of direct contact rather, and Miami-Dade being in the darker colors, suggesting not having as much direct contact. And again, with worry, how worried do you feel that you or someone in your family might become seriously ill? And so again, that might have an impact on your travel. So in our random forest model, I don't have time today to kind of get into the ins and outs of the model, and we're still very much, this is very much a work in progress and kind of tweaking things, but this gives you an idea of the kind of variables that we're looking at in our random forest model. And trying to really understand what the kinds of top factors that this approach might be telling us is particularly key that relates mobility and COVID-19 in a county. And here, these are some of the variables in our early work that we found important for looking at Miami-Dade. Mobility, so medium household income, having a graduate degree, trips has been important. Distance from the beach makes a difference in mobility and relating to COVID cases, unemployment. And again, so we're looking at a large number of variables, including the Facebook survey variables, to see what we can discern about impacts and relationships between mobility and COVID. So again, this is still fairly early stage, but I think we're getting some interesting results for these two counties. Continuing with this idea of mobility and health, we also have a project about understanding space-time human mobility patterns for malaria control. And this project involves using a multi-agent mobility simulation model. This is a project with support from the National Institutes of Health, and Yao Li is a graduate researcher involved in this project. So we are working with malaria study that's based in Myanmar in the Greater Mekong Subbasin. And so we are looking at mobility patterns of local villages in An Township in Rakhine State, an eastern part of Myanmar, and wanting to understand the degree to which mobility may be a factor in vulnerability to malaria infection for villagers or transmission of infection. And so we are developing a multi-agent mobility simulation model to simulate movement. We have a travel history survey, which gives us information on mobility. And we're looking at mobility patterns for different travel modes. For example, individuals who tell us that they walk to work every day versus individuals who may use a motorcycle, which is pretty common to see in Southeast Asia. You'll notice that more of the road network is being covered by travelers on their motorcycles, not surprisingly. But in this area of Myanmar, we have many more walkers actually than motorcyclists. It's a very rural area. And so we're using the simulation model to be able to simulate movement and learn about movement and understand especially movement by individuals who have been tested to be Plasmodium falciparum positive, which is the most serious kind of malaria, and looking at relationships then between different travel modes as well as different occupations, as we see here with plantation workers, farmers, loggers. And so building up a comprehensive picture of mobility and relating it to quantitatively to falciparum positive cases and using mapping to give us this geospatial perspective. Finally, the third study to mention today is a project where we are investigating spatial patterns of risk for drug-related emergency department visits in the greater Baltimore, Maryland region. This is a partnership between the Center for Substance Abuse Research, which has had support through the Empower program, University of Maryland's medical school with College Park. And we have been collaborating as well on this to look at pattern. We have data from 4 different emergency departments in the University of Maryland health system, and we have data from January 2016 to the present day. This study that I'm showing you here uses data up to the end of December 2019, so just pre-COVID. And so we are looking at spatial patterns of emergency visits for a drug-related health problem. And we're interested here to use spatiotemporal regression models to create probabilistic risk surfaces of these ED visit rates and to understand the factors that might be involved. And we've been focusing on 3 drugs in particular, heroin, cocaine, and methadone. We hope to extend this work and look also at fentanyl. And we've been, so some of these preliminary results we're showing here are modeled posterior exceedance probability maps for these 3 drugs for this region of Maryland. And basically the takeaway, the short and sweet takeaway, is that we do see a different spatial pattern between the drugs. And for cocaine, for example, versus heroin versus methadone. And so we are seeing spatial differences in the context for these emergency department visits. And so that's really my last slide, Kim. I look forward to more discussion later in the Q&A session.
Thank you, Dr. Stewart. Very interesting studies, very timely. Exactly the kind of work that we're proud is being done here at the University of Maryland. So let's go to our next presenter. Our next presenter is Dr. In-Kyung Chai, who I've already introduced as an associate professor here in our College of Information Studies. Dr. Chai's research focus is to empower individuals to help them make positive behavior changes through fully leveraging their personal data in the fields of human-computer interaction, ubiquitous computing, and health informatics. Putting people at the center of data flow, she examines 3 specific interactions between individuals and their personal data. Data collection on the one hand, data exploration, and finally, data sharing. Using human-centered design methods and mixed method approaches, Dr. Chai aims to understand people's challenges and needs regarding how people interact with data to design, develop, and evaluate web and mobile application visualizations and multimodal interactions. She applies these approaches to various health contexts, such as improving patient-client-clinician communication and patient care, leveraging patient-generated data, helping individuals form healthy habits, designing low-burden self-monitoring tools, and providing feedback and visualizations for data insights. Today, Dr. Chai's presentation is titled Ubiquitous Data Collection, Self-Tracking with Mobile, Wearable, Embedded Devices. Dr. Chai?
Hello, everyone. Thank you so much for the introduction. So while Catherine spoke about the research mainly using the passively collected data, today I will be talking about research that involves actively collected data and how to design better tools to collect quality self-tracking data to be specifically. I am a human-computer interaction researcher interested in using personal data to empower people. I design data collection tools, visualization, and feedback systems to help people gain insights from their own personal data. And I do this work in the context of improving people's health and well-being. Consider Alex, who is a health researcher, and he aims to understand what factors aggravate paranoia patients' symptoms. by collecting in situ data such as location, social interaction, and activities. Or suppose you have IBS or irritable bowel syndrome, and the doctor does not know what triggers it. And in fact, the doctor asks you to collect data, the food and your symptoms, so that the doctor and the patient can make sense of the data to better understand the disease. And this is an example of self-tracking. While these two stories are quite different, they share many commonalities and data collection challenges. How to support personal data tracking in these different contexts is the subject of my research. Personal data tracking is not new. In fact, lay individuals have been collecting data for a long time. More than 100 years ago, this coin-operated public vending machine called penny scales enabled the public to watch their weight without going to a doctor's office. And nowadays, people track many different kinds of data using their own devices that are mobile, wearable, and embedded. And moreover, researchers are tapping into the data collected by these commercial devices. However, these commercial devices are often not flexible and not inclusive enough to meet people's diverse needs. For example, when Apple's iOS Health first came out, they did not support one of the most common things that people track, menstrual cycle. And people were bounded by how the tool was initially designed, and they could not modify or add a new tracking element. Data access is another big problem with consumer health apps. Even when you contributed in collecting your own data, about 10% of apps do not provide any means to access the raw data. In general, there are 3 different ways to access data. First, you can synchronize the data with a health platform such as Apple Health, and then download the data from the platform. Second, you can download the file directly from the app. And lastly, you can use application programming interface or API to access the data. And we found that trade-offs exist across these different access methods regarding the required skills and granularity of the accessible data. So the more fine-grained data people want to access, the more advanced skills they need to have. APIs provide finer-grained data, but are difficult to use, and health platform and file downloads are easier to lay individuals, but they typically put a significant limit on data format, granularity, and the amount. These limitations constrain people from easily repurposing the data, even if they could get some of their data. So my approach to address some of these challenges is to facilitate personalized tracking experience. As a first step, we enabled people to construct their own trackers composed of different building blocks of data for different people. To create flexible trackers, we first proposed a concept of semi-automated tracking, combining both manual and automated ways to track data. To combine the best of both worlds, we designed and developed the OmniTrack system, which is a mobile platform that enables people to build their own custom trackers without programming. With OmniTrack, people can create a variety of trackers exclusively on their mobile devices, from breakfast tracker to smoking log. In the clinical context, clinicians can use our tool to create a custom tracker for each patient. So for example, in the context of food tracking, Depending on whether you have diabetes or eating disorder, your tracking needs are quite different, and the tools should be different as well. So this is a tracker that one dietitian designed when given a chance to create a custom tracker for an eating disorder patient. These custom trackers can help patients track the kind of data that would help the patient as well as the clinician and keep the patient accountable. Going beyond traditional mobile and wearable devices, we are now examining speech as a new input modality to capture data. Smart speakers operated by speech is promising in helping people capture data in a more flexible and natural way. However, smart speakers' main drawback is in its lack of visual component. Speech interaction also poses privacy concerns, as what they speak can be heard by other people around them. So we are using speech as an additional modality that complements and augments mobile and wearable devices. And I believe that speech should be particularly useful when people are occupied, for example, exercising, eating, or driving. In the same vein, we have recently embarked on a project designing multimodal data tracking systems, leveraging speech and touch interactions on a variety of devices. We will collect personal data to build personalized models to design inclusive self-tracking systems for older adults. User-generated labels are expensive and hard to get in people's own environment, especially from the marginalized groups. In this project, we are hoping to create a self-tracking system that can benefit both the researchers and the end users. Researchers can use the labeling data to build personalized and more accurate models, while older adults will be engaging in data collection as part of their self-tracking their own behavior. Thus far, I talked about various ways to collect in situ personal health data. To collect high quality data, maintaining high engagement from the end user is the key. To that end, I argue that we should start from designing a data collection tool that best suits the research goal as well as individuals' tracking goals. And while doing that, I encourage to leverage multimodal tracking to reduce data collection burden. And lastly, we should think about ways to provide values to those who contribute in data collection, whether that being the benefits induced by self-tracking or easier data access. And through these measures, I do hope to empower both researchers and individuals. Thank you. And my work is generously supported by NSF, NIH, and Microsoft. And these are my students and colleagues.
Thank you, Dr. Chai, for that very exciting presentation. And I'm sure that people will have questions at the end. In fact, let me remind all of the people attending that we have a Q&A box down at the bottom of your screen. If you have questions, please go ahead and type them in, because our next set of presentations will conclude our session, and I'll go to the Q&A and I'll put the questions that you generate to the presenters. So let's go to our colleagues, our partners from Facebook. First, we'll hear from Catherine Katie Morris. I introduced her earlier. She's a research scientist at Facebook. Catherine Morris is on the demography and survey science team, and she works on web surveys that inform decisions both within and outside of Facebook, with a focus on survey measurement strategies for machine learning around truth, learning that ground truth. Catherine received her BA in sociology from the University of Chicago and her MA and PhD in sociology from Harvard. At Harvard, she was a graduate affiliate at the Institute for Quantitative Social Science and a research fellow at the Center for Population and Development Studies. Her graduate work used quantitative and qualitative methods to explore the association between health and larger social contexts in which individuals are embedded, including network structures, neighborhoods, and policy settings. Prior to Harvard, she worked at NORC at the University of Chicago, where she was the project coordinator for the National Social Life, Health, and Aging Project, and supported numerous other projects within the Population Research Center and the Center on Demography and Economics of Aging. She'll be joined by her colleague, Sarah LaRocca, who is also a research scientist in the Demography and Survey Science Unit at Facebook. Dr. LaRocca works on web surveys as well that inform decisions both within and outside of Facebook. Dr. LaRocca received her BS in environmental science from the University of North Carolina and her MS and PhD in environmental systems engineering from Hopkins, Johns Hopkins. At Hopkins, her research focused on risk and reliability analysis for critical infrastructure systems, particularly in the context of natural disasters and decision-making for public health. Prior to joining Facebook, she worked on survey research at the Messina Group, a political consulting firm in Washington, D.C., and on the Hillary Clinton presidential campaign. So let's hear from Dr. LaRocca and Dr. Morris, and then we'll go to Q&A. Dr. Morris, Dr. LaRocca.
Just sharing our screen. All right, so good afternoon, everybody, and thanks so much for this introduction to participate in this really exciting launch. We're presenting today on the partnership between Facebook and 2 academic institutions to field a COVID-19 daily tracking survey, including both Carnegie Mellon University and, of course, the University of Maryland. The goals of our presentation today are to describe the data collected since April 2020, to highlight challenges we encountered over the course of field collection, and to share early insights from researchers who are using the data. We should emphasize here that while we do not have a formal acknowledgement slide in this deck, because there'd be, frankly, far too many people to list, but of course we are indebted to our colleagues at the University of Maryland who have been leading this effort for the Global Symptom Survey, and to our colleagues at Carnegie Mellon. So this partnership between our institutions was the direct result of a call from public health experts to build a rapid syndromic surveillance system for COVID-19. Syndromic surveillance enables policymakers and public health systems to make decisions before diagnosis data are available. Using Facebook as a sampling frame for this effort offered several unique challenges. Most importantly, Facebook reaches large segments of the global several unique advantages and challenges. Most importantly, Facebook reaches large segments of the global population daily at a greater scale than is previously possible, and with a technical infrastructure to provide bias correction. While there are certainly biases in any global social media tracking survey, we hope the trends in the weighted survey responses will enable important modeling and decision-making efforts. For example, forecasting how many local clinics or hospitals will see cases they will see in the days ahead, providing an early indicator of where the outbreak is growing and where the curve is being successfully flattened, and assessing the social and economic effects of the pandemic, as well as adherence to preventive policies. We designed the partnership with privacy in mind from the start, but this required special considerations for the structure of the project and its scientific components, which my colleague Sarah will discuss now.
Hi, everyone. So each day, Facebook invites a new random sample of users to participate in the survey. And users may take the survey more than once over the course of field collection, but their responses cannot be linked over time. CMU and UMD then aggregate the data and create weighted estimates, which are made publicly available. And the non-aggregate microdata are available to researchers by request. So we have 2 surveys. We have a global survey and then a US specific survey, which are fielded independently, though we have made the instruments comparable in important ways. The UMD Global Survey instrument is available in more than 50 languages, and the survey instrument has 5 sections. The survey was developed in partnership with academics across multiple institutions in the US and abroad. And we also worked extensively with technical staff at the World Health Organization to collect feedback and suggestions for developing the instrument. Facebook then translated the survey, and internally we conducted an extensive translation audit, which was then also further checked by UMD, who did a back translation effort to validate each of the translations that we had. And this level of care was really important because we had such a large cross-national survey of symptoms, and especially considering the specificity of some of the COVID-19 distinguishing symptoms, such as anosmia, which is otherwise known as loss of smell, and difficulty breathing. So we really needed to make sure that we had good quality translations there to get a good measurement. The CMU US survey instrument is available in 6 languages, including English, and also has 5 sections. One of the big differences between the 2 surveys is that the CMU survey has an emphasis on symptoms among others in the household, as well as symptoms among others in the respondents' community. And these components have proven extremely useful for improving the accuracy of CMU's forecasting models so far. And we are continuously working to improve the survey instruments, particularly given that COVID-19 is kind of an ever-evolving experience for everyone, and we'll continue to make the 2 instruments even more similar in the future. So as of September, we have received more than 20 million responses to the UMD Global Survey from respondents in more than 200 countries or territories globally. And we've averaged 230,000 responses every day, and which works out to 1.6 million responses every week. And then in the US, we've received more than 10 million responses to the CMU survey, which has meant an average of 71,000 responses every day and about 500,000 responses every week. So I'll turn it back over to Catherine now to talk a little bit more about our weighting methodology.
Facebook provides analytic weights that adjust for non-response and coverage biases in the survey samples. Survey weights are available for 115 countries, including the United States, and we may revise that set of countries as the field collection continues and we and our partners assess the sampling coverage. By non-response bias, we mean that, of course, some sampled users are more likely to respond to any given survey that we might send to them. To adjust for this, Facebook first calculates the inverse probability that sampled users complete the survey using their self-reported age and gender, as well as other characteristics from their profile that we know correlate with non-response to our web surveys. We then use these inverse probabilities to calculate weights, after which the survey reflects the active adult user population for the Facebook app in that geographic entity. By coverage bias, we of course mean that not everyone in every country has a Facebook app account or uses their account regularly, which of course will influence coverage bias of the sampling frame. To adjust for this, Facebook adjusts the weights created in the first step even further so that the distribution of age and gender in the survey sample reflects that of the general population. And in most of the weighted countries or territories, this adjustment also corrects for the distribution of the population across subnational administrative regions in order to correct for biases towards urban centers. Making these adjustments using the weights ensures that the sample more accurately reflects the characteristics of the target population represented and is strongly encouraged for any web survey of this type. However, we encourage researchers to consider whether further adjustments are needed for their use case. There are also promising signals of the validity of the symptom survey data and promising signals that they are complementary to data sources from which we can answer time-sensitive public health questions. And of course, in the US, especially, this might include the testing data. So for example, this graph shows the correlation between the rates of COVID-like symptoms from the CMU US survey in each state and correlates it with the rates of diagnosed disease burden from testing data. And you can see that in the places where we had large outbreaks in the US, there is a stronger correlation. So there seems to be some trend there. Aside from both Carnegie Mellon and Maryland, there are now 15 institutions who are working with the non-aggregate data from at least one of the two surveys. With a large global user base, Facebook provides a unique window into the world, and we believe strongly that when privacy is protected and data shared responsibly with the communities that need it, it can improve well-being and save lives during this pandemic. The data are available for responsible use, and we certainly hope you'll use them in your research. The aggregate weighted estimates of COVID-like illness, as mentioned previously, are hosted publicly by both Maryland and Carnegie Mellon, using both their APIs and public dashboards. The non-aggregate microdata are also freely available by request through a portal on Facebook's Data for Good website. In addition to partnering with Maryland and Carnegie Mellon to collect the symptom surveys, we provide several additional data sources to help with disease modeling efforts through the Data for Good program. We also encourage you to investigate these for your work, since they are meant to be complementary to the symptom survey data. If you have any questions, please feel free to reach out to us via our project email. We look forward to the discussion in Q&A.
Thank you, Dr. Morris and Dr. LaRocca, for insight into the work that Facebook is doing in this area. Much appreciated. So we have right now one active question in the Q&A field. And I do have a question that I will put to the entire panel. I think I'll start with my general question, and then I'll go to this specific question we have for one of our panelists from the University of Maryland. But for all of you, here's my question. Everyone paying attention to these issues, they think about three things that have to be balanced. And I want you to give us some insight into these three things. How does one being an individual researcher or one being an institution, balance the need for privacy versus developing the utility of an instrument or tool or method versus developing ways to continue the work, developing resources. In some sectors, that might be commercializing the instrument or the method. In some instances, it may be pursuing research dollars to do so. But for each of you, how does one or how should your field balance these three factors? And all of you, the panelists, if you would, unmute yourself, and jump in one by one and respond to this question.
I'm happy to start on this one from the Facebook perspective. From the Facebook perspective, we of course want to prioritize our users and what they came to our platform to do, which is to connect with their family, their friends, and their local communities. And so that is the utmost priority for us, is to ensure that they have a safe and enjoyable, fun user experience. So for us, priority always has to be, privacy always has to be the #1 priority, and we start with privacy. We then go from there to say, within the framework of privacy protecting procedures that we can put into place, what are we able to do to help serve the public good and to help academic researchers who are working in this space. So for us, privacy is always the #1 concern from the very start, and we go from there.
Others?
Yeah, sure. I'd be happy to say something too. So yes, absolutely. Privacy must be maintained and respected. And on the in geospatial science, we consider issues of scale to help mitigate privacy concerns. So we might look at problems from the aggregate, for example. There's been a lot of discussion with contact tracing and these kinds of requests really and needs for measures that will and methods that will allow us to take these on and still protect privacy, because it's absolutely key that we're able to protect privacy. So this is really an area of research in and of itself that we need, more research done on privacy-based approaches to tackle some of these questions, because there are some hard questions to ask some potential trade-offs, and yet I think, you know, we all work forward with the idea that we must protect privacy.
Dr. Chai, Dr. LaRocca, anything to add?
So I echo with all the other two panelists about the importance of ensuring the privacy and protect the privacy of the participants. And in my own research, because I collect data in the context of self-tracking, we are really dealing with really personal data. So I make sure that people understand what kind of data is being captured. And we make sure that they only report and track the kind of data that they feel comfortable capturing and not share anything else. And also we make sure that people do have access back to their data, either during the study, if the feedback is not changing their behavior or changing behavior is okay during the study, or after the study, when study is done, we make sure that people do have access to their own data.
Dr. LaRocca, we've already heard from Facebook, but I'm assuming you're not attached at the hip and you have your own thoughts about this?
Yeah, so to tack on to Dr. Stewart's point, I think one of the benefits that we have with the survey that we're running now is scale. And that's exactly why we have only publicly released aggregate estimates. So this helps us balance being able to release useful data to decision makers and get things out really quickly while still protecting individual privacy. And then we do make the microdata available to academics and researchers who have shared an extensive research plan with how they're going to use the data and who are going to enable additional privacy controls with the data use, which really helps us, again, to continue to maintain privacy.
Thank you. So Dr. Chai, early on, we have a question from the audience, and this is directed at you. You can see it in the Q&A box, but it reads, your vision for empowering individuals to have more access to an agency with their tracking data is admirable. However, the statistical skills required to make sense of these data is formidable. How do you pair your access vision with the requisite knowledge, skills, and tools to make it personally valuable?
Thank you for this question. This is a really important question. Today's topic for my talk was focusing on the data collection side, but how to provide insights, how to provide feedback, how to design visualization systems to provide feedback to the end users is a whole topic for a whole another topic. But I can quickly talk about some of the approaches that we are using in our research. So in the personal data context, we are looking into the kind of insights that lay individuals want to look at from their own data. So we already know the kind of personal insight types that people are looking for. So based on that, we are providing and designing visualizations that can best present the kind of insights that people are looking for. But more recently, we've been incorporating speech as a way to have a conversation with people's own data so that they don't need to know statistical skills, but they can ask questions using speech. And then we show visualizations or some feedback to answer the questions that people pose using speech. So it's more like having a conversation with your own data. So that's one approach that we are taking to address that exact question.
Okay. So this question is for Dr. LaRocca and Dr. Morris. It's a logistics question. Did the CMU survey invitation appear on people's feeds or somewhere else, or was it on just Facebook or the entire family of Facebook apps?
So this, the invitation for both surveys is seen at the very top of people's newsfeed. They have a week for which they are eligible within the sample, and then they can see the invitation up to 3 times before we assume that they are not interested in participating. It is only available on the Facebook app, but it is available both for Facebook primary mobile users as well as people who primarily use Facebook on their desktop.
Okay. Great. So this is a whole panel question. Maybe all of you have a response to it, but maybe not. Maybe we should just take one answer because we really have to wrap up. And it extends the question about statistical skills and tools needed for customizing an app, as Dr. Che addressed, but also literacy. Would anyone like to chime in on the literacy levels necessary for social data collection and health? And you might even talk about health literacy. Unfortunately, we only have time for one person to jump in and respond. Or not.
I can really talk briefly. So literacy is important in general in collecting the quality data, in understanding the feedback. But literacy is a really loaded term. So we think about literacy from different perspectives: data literacy, visualization literacy, numeracy, and health literacy. So depending on who you're talking to, people will use different terms. So in the personal data context, we try to provide the kind of feedback that lay individuals can understand. And I believe that there's a lot of promising approach in using natural language, speech-based feedback so that anybody can easily understand and ask questions.
Okay, great. So thanks to all the panelists for participating in this very exciting area of research in this launch. Now I'm going to turn it back over to Dr. Crowder and Dr. Butler to close us out. Once again, thank you for participating.
Thank you, Kim, and thanks everybody else on the panel for the great presentations. I really enjoyed this work here, and it's a good opportunity for me to point to the next 2 days of launch event. In particular, with all the questions on privacy, I want to make sure you noticed here that on day 3, we have a whole session dedicated to this. But I also want to take the opportunity to thank Felicia Metz and Deborah Auerbach, who has been working relentlessly to get these contracts for the use of the microdata in place here at the University of Maryland. Those folks behind the scenes are often not mentioned enough. Well, thank all the ones that helped launch this event throughout the week, but Jody Williams in particular, our executive director, should be mentioned here explicitly. And she and of course Brian and I look forward to welcoming you tomorrow at 1 p.m. for the business and economics talks. If you have any questions in between, feel free to email us and visit our website. And if you want to get involved, let us know. And otherwise, we'll see you tomorrow. Thank you.